Sensory functioning. I wanted to pull this piece of our physical assessment part 2 out for your flipped classroom content, and we'll just address a few of the elements of sensory functioning. First, sensory functioning is a combination of two components, and that is the reception and perception of information. Sensory reception is the process of receiving data about the internal and the external environment through the senses, and the senses being the visual senses of seeing, the auditory sense of hearing, the olfactory sense of smelling, the tactile sense of feeling, the gustatory sense of tasting, and the kinesthetic sense of position and movement, awareness of the body. All of these are able to give off stimuli, receive stimuli that the body is able to receive. So what is a stimulus or stimuli? An agent, an act, or an influence capable of initiating a response by the nervous system. That has to be present. There has to be some kind of stimulus, one of those senses, that is received by the brain. The impulse conduction is that movement along the nervous pathway for the receptor or the sensing organ to receive. So it's the conduction of that message. And then once the message has been received and taken along the path there, then it is perceived in some kind of hopefully meaningful sense. And all of those receipts of those messages, or the receipt of stimuli, is actually happening through this reticular activating system, the RAS. I wanted you to see this picture. It kind of helped me. Your book gave some words to it, and just a nice picture. And that is when we're looking at the reticular activating system, it follows or extends from the hypothalamus to the medulla, and it mediates arousal. So in this picture, you could kind of see where the visual impulses are received, and where the auditory and so forth are, the touch, pain, temperature are received, and then the messages are sent out into the different areas of the cerebral cortex to be acted upon. So what does it mean to be at different levels of arousal, if you will, awakeness or alertness? And the first word that we want to be familiar with is sensory stasis, which is the optimal arousal. So when the reticular activating system is receiving everything and messages are in a state of balance of internal, external stimuli and receipt, then we're at our optimal awakeness, and I don't even know if that's a word, and we're our optimal arousal, awake. When someone is in a state of sensory arousal or awareness, they're able to perceive internal and external stimuli and respond appropriately through thoughts and actions. And the truth is, everyone has their own level of optimal arousal, and it can fluctuate throughout the course of a day. Sensory deprivation, on the other hand, is the balance in the reticular activating system is disturbed, and the RAS is unable to maintain normal stimulation to the cerebral cortex. So those little arrows don't go out as evenly as before. Because of reduced stimulation, a person can become more acutely aware of the remaining stimuli, and they can perceive what's remaining in a distorted manner. So basically, it's a sense of a decrease in meaningful stimuli that causes an imbalance in response and reaction. Sensory overload is on the other end of the continuum, and that would be an increase in quantity or quality of internal stimuli or external stimuli, or both. which results in often an inability to disregard the stimuli selectively. There's just so much noise, whether it's internal processing or external, and the person is just unable to sort through all that. Sensory overload. I think of the client that may be in an intensive care unit and people are busy and talking all the time, and they're on machines and monitors that are beeping or humming or whirring all the time. Visitors in their room, sounds and noises that just are bombarding their senses. And so it may be, they may feel overloaded and they just can't disregard or shut those sounds out, and it affects their ability to interact effectively with the environment. Sensory deficits are a person's impaired reception, perception, or both. And so it may be someone that's blind or deaf or vision impaired, just as some pretty simple definitions or examples of a deficit. And a new one to me that was in your textbook was this idea of sensory poverty. And I thought that was interesting, that we're living in an age where, because of all of our high-tech devices that are just bombarding our senses all the time, we're learning about the world without experiencing it. We're not smelling the roses. We're not getting out and walking in the grass barefoot, or, going to the beach. We're not experiencing life through our senses like we used to. Interesting. I like how she asked at the end of the paragraph, do you agree with Ackerman that our lives are becoming poorer as we lose the ability to be sensually present in the moment to the world around us? I think it's worth pondering. I did want to focus on the confused client and just make some distinctions about how we might experience some confused clients in our work. And there's two categories of confusion, one being delirium and the other dementia. And they're distinctly different, even if they present themselves in a single moment similarly. The difference is, if someone is confused and it's an acute situation, like maybe after a surgery or after an injury and they're hospitalized, then it's considered a delirium. So by definition, delirium is an altered state of consciousness consisting of confusion, distractibility, disorientation, disordered thinking and memory, defective perception, maybe some illusions or hallucinations, prominent hyperactivity, agitation, and autonomic nervous system overactivity. And it's acute. The data shows that about 40% of hospitalized patients following a surgery will experience delirium. And then I've read in another text where delirium occurs in 25% to 60% of hospitalized patients. So just changing that environment and illness and so forth can affect people's neurostatus related to their sensing and their orientation. So delirium is acute, it fluctuates, it's sudden, it's temporary, it will resolve as the client's condition resolves. It worsens at night. They may have fluctuations in alertness, so maybe tired, lethargic, somnolent during parts of the day and then awake and so forth. And then they may have hallucinations. You'll notice that dementia has delusions. So let me explain what hallucinations are. Let's differentiate between the two. And a hallucination is the subjective perception of an object or event when no such stimulus or situation is present. It could be visual, like they're seeing snakes, or auditory, they're hearing people talking about them, or olfactory, smelling things, gustatory or tactile. Any of the senses could be affected, but they're perceiving it as real when it's not. Dementia, on the other hand, is the umbrella term for that disease condition, and it's generally a term for a loss of memory or other mental abilities severe enough to interfere with daily life, and it's caused by physical changes in the brain. Alzheimer's falls into this category of dementia, and it accounts for 60 to 80% of dementia cases. So dementia is a memory impairment. It is slow and insidious. It's chronic versus acute, and it's irreversible. There's no change throughout the day, and the client is generally alert, awake. They don't fluctuate in alertness, and they have delusions as opposed to hallucinations. All right, so what's a delusion? A delusion is a false belief or wrong judgment held with conviction despite incontrovertible evidence to the contrary. So it might be, maybe you've heard the term delusions of grandeur. They think they're the king or the queen of the land or something. It's a belief system more than it is a sensory perception. And what can we do to help orient clients when they have acute confusion or delirium? Wear readable name tags. Address them by name. Introduce yourself frequently and remind them of the time and the place. You may have to ask where they think they are to see where the orientation is, and orient them. Put a calendar or clock in the room. Mark holidays so that they can see. Speak clearly and calmly. Yelling or speaking louder does not make it any more true, so be patient. Don't take their confusion personal, and working out your frustration on them is just not effective. You just need to calm down and help orient someone. Encourage family or friends to visit frequently. Give clear, concise explanations, and you may have to repeat them. Eliminate unnecessary noise. Provide adequate sleep. Keep their sensory aids within reach, their glasses, hearing aids. Ensure that they get adequate pain management, and keep their rooms well lit during waking hours. And those are some things that may help the acutely confused or the delirious client as compared to a dementia. And some of these things may work with a dementia as well, and they are certainly worth trying. All right, if you have any questions about those, bring them to class, and we'll continue to look at assessments of our clients.